Hello students, welcome to today's class. I am Bernisha, lecturer from Emmanuel College of Pharmacy. Today we are going to discuss about another topic from pharmacotherapeutics, that is tuberculosis. I know that tuberculosis is a commonly spread disease in this world. So in this slide, we are going to briefly discuss about what is tuberculosis, its etiology, pathogenesis, along with the pharmacological and non-pharmacological managements. Let's get into the video. First, let's see what is tuberculosis. Tuberculosis is a communicable chronic granulomatous disease. Usually, we have in the last video we have learned about asthma. Asthma is a non-communicable disease, so it won't transfer from one person to another. But tuberculosis is a communicable disease. So, communicable disease means it is a chronic granulomatous disease which is mainly caused by the bacterium, that is Mycobacterium tuberculosis. It's the bacteria which is mainly which is responsible for the tuberculosis. It's mainly usually involves in the lungs, but it also may also affects the any organs or tissues in the body. Typically, the centers of tubercular granulomas undergoes cautious necrosis. In this picture, we have seen that here the tuberculosis affects the lungs, which is affected by the Mycobacterium tuberculosis. Here, the Mycobacterium tuberculosis mainly affects the lungs. Usually, the tuberculosis is mainly affects the lungs, but sometimes it may also affects the various organs of the body. Next is the etiology of tuberculosis. The etiology of tuberculosis means how does the tuberculosis is caused. Here mainly it is caused by the tubercular bacilli bacteria, which is belongs to the genus of Mycobacterium. So the Mycobacterium species, which includes Mycobacterium tuberculosis, Mycobacterium bovis, and Mycobacterium africanum. Here this Mycobacteria, which is other than tuberculosis, mainly around 15 species are recognized as the pathogenic species to the humans, as they causes some of the pulmonary diseases resembling towards the tuberculosis. And usually they are found in soil, milk and water. So they are also referred to as the atypical mycobacteria. So here we know that Mycobacterium tuberculosis is the causative agent for the tuberculosis, and the Mycobacterium leprae is the causative agent for the leprosy. Next will be the types of tuberculosis. Usually, the tuberculosis is around two types. They are pulmonary tuberculosis and extrapulmonary tuberculosis. We have already studied that. Pulmonary tuberculosis, which includes that the site is around lungs. So, in pulmonary tuberculosis, it's mainly involves in the lungs and pleura. Pleura is nothing but the cavities present inside the lungs. So, it's mainly involves in lungs and pleura. So, 85% of all the TBs are in pulmonary tuberculosis cases. Next, it is also classified into primary tuberculosis and secondary tuberculosis. Next will be the extrapulmonary tuberculosis. We have learned that pulmonary tuberculosis means it is mainly involves in the lungs and pleura. Then the extrapulmonary tuberculosis means it includes some other so we have learned that the pulmonary tuberculosis is mainly involves in lungs and pleura. So it is also further classified into primary and secondary tuberculosis. So the extrapulmonary tuberculosis is also further classified into limnotuberculosis, genitourinary tuberculosis, skeletal tuberculosis, meningeal tuberculosis, gastrointestinal tuberculosis, disseminator and miliary tuberculosis, pericardial tuberculosis. So these are the extrapulmonary, that means which is other than that of the lungs or pleura. So here mainly 85% of the TB cases are in pulmonary tuberculosis, but some cases beyond that 15 cases are in extrapulmonary tuberculosis. Next will be the primary tuberculosis. Primary tuberculosis, which involves if the infection of an individual who has not been previously infected or immunized are called the primary tuberculosis. They are also known to be the Ghon's complex or childhood tuberculosis. Usually in primary complex or the Ghon complex is the lysine which is produced in the portal of entry with foci in the draining lymphatic vessels and lymph nodes. Usually, the lysines are produced in the lymphatic vessels and the lymph nodes. The most commonly involved in the tissues of primary complex are lungs and the hilar lymph nodes. Usually, these lysines are found in the lungs and hilar of the lymph nodes. The incidence of the disseminated form of the progressive primary tuberculosis is particularly in the high immunocompromised host. So this is the primary tuberculosis. In this, the infection of an individual who has not been previously infected or immunized is called the primary tuberculosis. Next will be the secondary tuberculosis. In this condition, the infection of an individual who has been previously infected or sensitized is called secondary or post-primary reinfections. It mainly comprises of the reinfection of tuberculosis. Primary means it's the first time infection and secondary means it's a reinfection of the chronic tuberculosis. It's mainly of endogenous source. That means it is the reactivation of the dormant primary complex and exogenous source such as fresh dose of reinfection by the tuberculosis bacilli. So these are the secondary tuberculosis. Primary tuberculosis is nothing but um, they are not previously infected. It's the first time they are getting infected. That is known as the primary tuberculosis, and the secondary tuberculosis they are previously infected or they are sensitized or reinfected. Next will be the risk factors. What are the common risk factors include in the tuberculosis, which involves low socioeconomic status, mainly the crowded living conditions, disease that weakens the immune system like HIV, persons or immunosuppressants like steroid healthcare workers, migration from a country with high number of cases, alcoholism, recent tubercular infections within last 2 years. So these are the certain risk factors which may seen in the tuberculosis. Mainly it includes socioeconomic status and crowded living conditions. So if the persons may affected by the recent tubercular infections, which may last within the last 2 years. Next will be the mode of transmission. Mode of transmission means how the tuberculate gets transmitted from one person to the another. So it may be one of the following routes, that is inhalation or ingestion or inoculation of tissues or transplacental route. Inhalation means they get inhaled the droplets of tuberculate bacilli. Ingestion means they get ingested the tuberculate bacteria. Next, inoculation of tissues. Inoculation of tissues and transplacental routes are some of the certain routes. If transplacental route means if the mother is affected by the tuberculosis, the child gets also affected by the tuberculosis through this transplacental route. Next will be the pathophysiology of tuberculosis. In this pathophysiology, mainly the virulent strains of mycobacteria, they get entry into the macrophage endosomes. Then the organisms are able to inhibit the normal microbicidal responses by the manipulation of endosomal pH and arrest of endosomal maturations. The end result of this endosomal manipulation is impairment of effective phagolysome formations and unhindered mycobacterial proliferations. Thus, the earliest phase of the primary tuberculosis, which is less than 33 weeks in the non-sensitized individual, is characterized by the bacillary proliferations within the pulmonary of multiple sites. And most persons of this stage are asymptomatic or have a mild flu-like illness. So these are the pathophysiology of tuberculosis in the primary pulmonary tuberculosis less than 0 to 3 weeks. In this picture, first the mycobacterium gets attached to the alveolar macrophage. So after that, it changes the endosomal manipulations and undergoes maturation arrest, lack of acid pH, and ineffective phagolysosome formations. After that, it may undergoes the unchecked bacillary proliferations, and there will be the replications of bacteria. Next will be the diagnostic tests. So what are the diagnostic tests mainly used in the diagnosis of tuberculosis or Mantoux test or tuberculin sensitivity test? Next will be the acid fast bacilli. Acid fast bacilli is the AFB test. Next will be the mycobacterial culture, and the next will be the PCR, that will be the polymerase chain reaction test, and the radiographic procedures. These are the diagnostic tests which is used to diagnose the tuberculosis in patients. Next will be the clinical manifestation or signs and symptoms of tuberculosis. So, usually the cough for 3 weeks or more, productive cough. Sputum usually mucopurulent or purulent. Hematophytis, fever with night sweats, tiredness, weight loss, anorexia, and malaise. These are some of the signs and symptoms of um, tuberculosis. Mainly the coughing that lasts 3 or more weeks. If not like similar coughs, it will be around a persistent cough. Sometimes it may accompany with the chest pain and the pain with breathing or coughing. Night sweats are also a major signs and symptoms in tuberculosis, along with chills and unintentional weight loss. Next will be the management of tuberculosis. How we can manage this tuberculosis? Mainly, first will be the choice of drugs. There are first line drugs as well as the second line drugs in tuberculosis, as well as the length of treatment, comorbidity, especially HIV infection, liver and renal diseases, adherence to treatment by the patient. Drug treatment, which involves treatment with anti-tuberculosis drugs that has been maintained with two purposes. First will be to cure people with TB and provided the bacilli or drug sensitive, and to control the TB by either preventing the development of infectious forms of reducing the period of infectivity of people with infectious diseases. Next will be the first line drugs of tuberculosis. The first line drugs mainly involves isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Nowadays, the first line drugs of tuberculosis gets also be revised. So the first line drugs used in the tuberculosis is isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. These are the first line drugs which is used in the treatment of tuberculosis. Isoniazid, mainly this isoniazid inhibits the biosynthesis of mycolic acid, which is an essential component of mycobacterial cell wall and results in the death of bacteria, that is tuberculosidal. It is active against both intracellular and extracellular bacilli. The adverse reactions, mainly it has some of the adverse reactions. It includes peripheral neuropathy, hepatotoxicity, skin rashes, arthralgia, GI disturbances, psychosis, and rarely convulsions. Mainly, this isoniazid inhibits the biosynthesis of mycolic acid, which is an essential component of mycobacterial mm, cell wall. Mycobacterial cell wall, which results in the death of bacteria. Mm, the dose which is used given for the tuberculosis will be 5 to 10 mg per kg, or a maximum dose of 300 mg per day for a persons. Adult dose will be around 300 mg per day, and usually it's around 5 to 10 milligram per kg. Next will be the rifampicin. Rifampicin binds to the beta subunit of the DNA dependent RNA polymerase enzyme and inhibits the mRNA synthesis in the bacteria. It has the bactericidal effect and it is active against both the intracellular and extracellular bacilli. The major adverse reactions includes hepatotoxicity, gastrointestinal disturbances, flu-like symptoms, headaches, drowsiness, dizziness, nausea, vomiting, hypersensitivity reactions, etc. The dose which have been given for the rifampicin includes 15 to 10, 20 mg per kg or a maximum dose of 450 to 600 mg per day. Next will be the pyrazinamide. Pyrazinamide is a first-line drug which converted the active form to active form of metabolic pyranimic acid by the enzyme pyrazinamidase present in the mycobacteria. This metabolite may inhibit the synthesis of mycolic acid by the mycobacteria and it requires an acidic pH of 5.5 for its tuberculosidal activity. So it may also inhibit the synthesis of mycolic acid by the mycobacteria. Next, what will be the adverse drug reactions? It includes dose-dependent hepatotoxicity, anorexia, nausea, vomiting, fever, skin rashes, malaise, urticaria, arthralgia, etc. The dose which will be given for the pyrazinamide includes 25 to 40 milligrams or a maximum dose of 3 grams per day. Next will be the ethambutol. Ethambutol inhibits the mycobacterial arabinosyl transferase encoded by the EMP enzymes, which is involved in the polymerization reaction of an arabinoglycan, an essential component of mycobacterial cell wall. It is the tuberculostatic and acts as fast multiplying bacilli in the cavities. It also effective against the atypical mycobacteria mutation of EMP gene. Adverse drug reactions. Adverse drug reaction includes optic neuritis, hypersensitivity reactions like skin rashes, itching, etc., fever, arthralgia, GI disturbances, headache, mental disturbances, etc. The dose will be around 15 to 25 mg per kg or a maximum dose of 800 to 1200 mg per day. Next will be the streptomycin. It is an antibiotic which is given in the treatment of tuberculosis. Its main mechanism actions, it reversibly or irreversibly inhibits the bacterial protein synthesis in at least 3 ways. The interference with the initiation complex of the peptide formation, misreading of mRNA, which causes incorporation of the incorrect amino acids into the peptide, resulting in the non-functional or toxic protein. Its adverse reaction includes dose-related ototoxicity, nephrotoxicity, ataxia, vertigo, rashes, fever, renal impairment, etc. The doses includes 15 mg per kg or a maximum dose of 0.75 to 1 gram per day. Next will be the second line drugs, that is ethionamide, cycloserine, paraaminosalicylic acid, rifampicin and rifampicin, fluoroquinolines, that is ciprofloxacin, levofloxacin, moxifloxacin, ofloxacin. Injectable drugs includes capreomycin, kanamycin, amikacin. Newer drugs which includes the bedaquiline and proteomanide. These are the second line drugs which is used in the treatment of tuberculosis. So, second line drugs, if they are resistant to the first line drugs, we have to give this second line drugs for the treatment of tuberculosis. If they have the serious areas, as we have studied in the first line drugs, if a patients who are affected by this areas, they can be given for the second line drugs. After the full guidance for the toxic effects, we have to only given for this second line drugs. And the next will be the ethionamide, which is we have already studied in the first line drug itself, which upon oxidation with the catalyzed peroxide is converted to active acetylating agent. Here it also sometimes causes intense gastric irritations, optic neuritis, hepatotoxicity. Here we have to take a dose of about 15 mg to 15 mg and per maximum dose of 0.75 to 1 gram per day. Next will be the cycloserine. It also inhibits the incorporation of D-alanine, which is the amino acids into the peptidoglycan or pentapeptide by inhibiting the enzymes alanine racemase. So, its main adverse reaction includes CNS dysfunctions, which includes depression, psychosis, peripheral neuropathy, seizures, tremors, etc. Dose, dose will be around 15 mg per kg or a maximum dose of 1 gram per day. Next will be the para-amino salicylic acid. This para-amino salicylic acid, which includes mainly it's sulfonamide, similar to para-amino benzoic acid and sulfonamides. It shows the similar action of sulfonamides. It inhibits the folate synthase enzymes and thus it inhibits the synthesis of cell wall. So major adverse reaction is gastrointestinal effects like nausea, anorexia, epigastric pain, diarrhea, fever, joint pain, peptic ulcer, etc. The dose is around 200 mg per kg or a maximum dose of 10 to 12 gram per day. Next will be the rifamycin and the rifapentine. So these are the derived from rifamycin, which is related to the rifampicin, which is so similar mechanism of rifampicin. So it inhibits the bacterial RNA polymerase enzymes inhibitors. It also has some adverse reactions, that is vomiting, drowsiness, dizziness, hypersensitivity reactions, etc. So the dose is around 300 mg per day. Next will be the fluoroquinolones. Fluoroquinolones, which involves typical and atypical mycobacteria. They inhibit the bacterial DNA synthesis by inhibiting bacterial topoisomerase 2 and topoisomerase 4. They have the tuberculosidal activity. So usually we are taken with ciprofloxacin, levofloxacin, moxifloxacin, ofloxacin with different doses. Usually it's given with PD, OD, PO, etc. Next will be the injectable drugs. Usually the aminoglycosides are given as injectable drugs like streptomycin. Usually the areas includes ototoxicity, nephrotoxicity, fever, rashes, etc. The doses which includes 15 mg per kg or a maximum dose of around 0.75 to 1 gram per day. Kanamycin will be 15 mg per kg or a maximum dose of around 0.75 to 1 gram per day. Amikacin will be 15 mg or per kg or a maximum dose of 1 gram per day. Next will be the newer drugs, that will be the bedaquiline, which also binds to the oligomeric and proteolipid subunit C of the mycobacterial ATP synthase. So it also increased the QT interval, which is the major areas of bedaquiline. The dose is around 100 mg, which is taken in oral. Next will be the pretomanid. Pretomanid is nothing but no areas are noticed still now. They are the bicyclic nitromidazole-like molecules. It is active against both the replicating and non-replicating organisms. It inhibits the mycolic acid synthesis through unknown molecular mechanisms, and thus it also inhibits the cell wall synthesis like isoniazid. Till now, there is no ADAs found in pretomanid, and it is relatively safe and well tolerated and efficacious. Usually, we have to take around 100 to 200 mg per day. Next will be the treatment regimen. Treatment regimen is nothing but most of the times we have to taken it for around 2 months. So first we have to taken along with rifampicin, isoniazid, pyrazinamide, ethambutol for the initial 2 months, which will be the first line drugs. And further 4 months of rifampicin and isoniazid, we have to given it for the continuous phase. So these are the treatment regimen mainly we have to follow, and usually it is followed in United Kingdom. Next will be the directly observed therapy. So this directly observed therapy is the major therapy which is given by the government to taking care of the tubercular patients. So here dot means nothing but directly observed therapy. Here where the patient is observed taking their anti-tuberculous medication by the healthcare professionals. But it is not needed for a case of active TB. A risk of assessment for the treatment adherence should be undertaken in all patients, and DOT regimens considered where non-adherence to the treatment might be a problem. So, if a tubercular patients who are not having any particular safer place or a good food or a good environment for their curing of drug, their people, the healthcare professionals would meet them, and they will, if they were with the active TB and were non-adherence individuals with chronic alcohol, other social problems, they will meet them and they will explain them about the disease, and they will give the full guidance about the drug they are going to take in during the anti-tuberculosis medications, and they will check the follow-ups as well as they will help them to complete the course of medications they are taken during this tuberculosis control management time. So mainly the advantages of the dot therapy is usually there will be the high cure rate. So the people who are in a helpless stage or dwelling or homeless people but with active TB, they can also get cured by this dot therapy, and they are also have decreased drug resistance, and areas can also be easily monitored as they are completely closely monitored by the healthcare professionals. So the areas can also be easily monitored. Okay, students, I hope this video is very much useful for the information regarding tuberculosis. In this video, I have completely learned about what is tuberculosis, its etiology, pathogenesis, along with their clinical manifestations and the drugs which are used in the treatment of tuberculosis. Okay, students, let's see in the next video with the another pharmacotherapeutics of another disease. Thank you.